Dr. Xiu-Li Zuo from the Department of Gastroenterology, Qilu Hospital, Shandong University in China. I would like to acknowledge my co-authors, Dr. Zhen Li, Jing Liu, Chong-Mei Yang, and Yanqing Li. We would like to thank the Journal of Endoscopy for their invitation for us to share our recent article, Screening for Upper GI Cancers with Magnetically Controlled Capsule Gastroscopy, a feasibility study. Upper GI cancers, including gastric cancer and esophageal cancer, have high mortality rates worldwide, especially in China. Most patients with upper GI cancers are asymptomatic, resulting in delayed diagnosis and even distant metastasis. National Cancer Screening Program is of great importance in reducing mortality. However, in China, the detection rates of early gastric cancer is still low, even in tertiary hospital centers. Several reasons may account for this. First, despite identified as gold standard, the application of EGD in mass screening is limited in China, mainly because of the large population size and a shortage of professional endoscopists. Second, people may deny EGD for health checkup due to uncomfortable experience, potential cross-infection, or sedation-related risks. Third, the EGD preparations such as withdrawal of antiplatelet agents may also lower their compliance. At last, the uneven distribution of professional endoscopists and endoscopic equipment between urban and rural areas is another reason. Therefore, acceptance of EGD as a part of routine checkup is still not optimistic, and the existing medical and public health system is less likely to meet the demands for massive cancer screening by EGD in China. The introduction of a feasible and accurate screening model for upper GI cancer screening has been ardently anticipated, especially for asymptomatic health checkup populations. As a simpler and non-invasive procedure, magnetically controlled capsule gastroscopy, MCCG, shows comparable diagnostic accuracy with EGD. Only technicians, rather than endoscopists, are required for MCCG procedure, and widespread qualified technicians in checkup centers partially overcome the current shortage and maldistribution of the experienced endoscopist. Moreover, through intense cooperation within a medical consortium, specialized medical resources from different levels of medical institutions could be fully utilized. So here's something else to consider: whether applying MCCG to medical consortium could create a feasible model for mass cancer screening and provide a new solution for this clinical dilemma. Herein this study, my research team and I decided to evaluate the feasibility of the medical consortium model in upper GI cancer screening among health checkup populations. A total of 6,627 asymptomatic individuals for health checkup were enrolled. The mean age is 47 years. Upper GI cancers were detected in 0.48% of the enrolled subjects. The incidence of gastric cancer was 0.36%, higher than those of previous studies. Of note, the detection rates of early gastric cancer was 16.67%, which was acceptable and in line with previous researches. The whole gastrointestinal preparation and operation process were well tolerated. This provides new insights for non-invasive early gastric cancer screening in high-incidence regions. It is important that we understand the feasibility of screening for upper GI cancers with MCCG within the medical consortium, because there are real medical and societal implications. What we want to do next is the development and application of MCCG quality controlled models using artificial intelligence. In this way, we try to achieve homogenized MCCG examination for every checkup center, regardless the regions in urban or rural areas. In conclusion, integrating healthcare centers and experts via the internet makes medical consortium with MCCG an ideal complement for intubated esophageal gastrointestinal in upper GI cancer screening. If used worldwide, it could be of potential benefits to countries that need gastric cancer screening and could provide high-quality evidence-based data. It may be helpful for early detection and subsequent treatment of patients with gastric intestinal metaplasia, gastric intraepithelial neoplasia, and early gastric cancer, and screening and surveillance for high-risk populations of gastric carcinoma. That's all. Thank you very much for watching.